Hello everyone. My name is Dr. Mayur Agrawal, DM Endocrine from Bhopal, Madhya Pradesh, National Faculty for Super Specialty Marrow Endocrinology. So I welcome you for this session. We'll be discussing today regarding CGM, that is continuous glucose monitoring system. Okay. So what basically CGM is? It's a device which is attached to your arm or abdomen, which continuously senses the blood sugar via the interstitial fluid. So it measures glucose level from the interstitial fluid. It is not the blood which where it checks the blood sugar. Okay, it can capture data right from every minute to 15 minutes, somewhere depending on what model you're using, which company you're using, and it can give you blood sugar in real time. That means at that time, what is the blood sugar of the patient, that would be reflected on the meter, and you would be also able to know the trends, that is whether it is going up, down, lows, highs, all those things, and the pattern means basically like if the post meal are high, or what we talk about is a somyoghi phenomena, where the blood sugars are dropped at night, and that is why there's a rebound rise early morning. So all those things you can get from this CGM data, and thereby you can actually change the medication, especially insulin, or you can make changes in the food. Let's say a patient is taking very high carb food, so post that the sugars may raise. Okay, or let's say the patient has erratic meal pattern, or let's say the patient is moving, going somewhere out on Saturdays and Sundays. So all those things you can get, and accordingly you can modify the food, you can modify the exercise, you can modify the exercise of the patient. Okay, all those things can be done. Then it will help you to know the glucose fluctuation, that is what is glycemic variability, the highs and lows. And actually after seeing that graph, the patient also understand that what is going on, and accordingly he is also more susceptible to what all changes you say. He'll be more doing it more rigorously, he'll be following all those things. And then it can be used alone, where sometimes like your HbA1c is not very accurate in all those hemoglobinopathies or anemia, so it can be used, or it can be used in combination with your HbA1c. HbA1c will tell you blood sugar, average blood sugars of past 3 months, mainly it's a past 1 month. And CGM data is usually, it's most of the device, most commonly we use here is the Abbott one, which is for 14 days. So that will give you blood sugars for past 14 days. Okay, and accordingly it will also generate an estimated HbA1c. I'm coming to all those things. Coming to HbA1c, we already know that past 2 to 3 months is mainly the 50% is reflected for past 1 month. It helps to diagnose diabetes, monitor diabetes, to check the effectiveness of your diabetes treatment. To there are some data, ample of data I would say, which correlates HbA1c value with the complication. That is why we are treating diabetes, right? So all those things we know about this. But what it does not provide is information about the fluctuation. It's a value which is over 3 months. Let's say patient has too many high and too many low, many hypers and hypos. So average would be normal. So it can be falsely high, it can be falsely low, it can be falsely normal. Let's say a patient having too many times, like many times the sugar is dropping to 60 also, and many times it is increasing to 300 also. So his HbA1c may be normal, right? So that is important. Then it does not tell you about the magnitude and frequency of inter and intraday glucose variation. Now, what is intraday? Intraday means it's within a day, same day. What is the fluctuation? Interday, that means at the same time during different days, what is the blood sugar of your patient? That is interday variation. So HbA1c will tell you just the average. It cannot tell you about the variations, and it may not be accurate in few condition, like let's say anemia. The RBC lifespan is slightly increased, so your HbA1c is falsely high. And now you treat, let's say, a patient of iron deficiency anemia. Now you have given iron to that patient. So what will happen? Within a week, reticulocyte count would increase, and this will falsely drop your HbA1c. So it can increase, it can decrease, anything can happen. So that also you have to keep in mind while you evaluate this, while you interpret the report of HbA1c. Okay. Now, basically, initially, what we used to do is to manage glycemia. Then came the concept of hypoglycemia. So what we are targeting was HbA1c and hypoglycemia is to be prevented. Now there is something called as glycemic variability also. So even with a good HbA1c, patient can have high glycemic variability, which will predispose our patient to complication. And that is why we are treating diabetes. That is what we want to prevent. So with each high sugars, let's say post meals are high, that's a high glycemic variability, right? Many highs and many low, this will actually increase the complication. Not only hypo also increase. Now we have data which shows that nocturnal hypoglycemia is associated with cardiac mortality morbidity. We know that, right? So there are three parts to be taken care of: HbA1c, hypoglycemia, and glucose variability or the glycemic variability of the patient. So this is what I was talking about. Let's talk about, these are the three patients. Okay, here you can see there is too much high. The blood sugars are going somewhere up to 300. It is also dropping to somewhere around 50. Okay. Similarly, in the second, it's not that high and not that low. In the third, it's not high, it's not low, it's absolutely perfect. But if you see in all these three, the HbA1c can be same as given here the example of 7%, right? So if you have a patient who have HbA1c of 7, that is what we are targeting. So you would say, okay, our patient is doing very good, he's very fine, and what we were targeting we have achieved. But it's not. See, first one, the patient is having too many highs. The time in range is just 40%. 40% of the time the blood sugars are high, and 20% of the time the blood sugars are. So here you can see the first one, 40% the sugars are high, 40% the sugars are in range, and 20% of the time the blood sugars are low. Whereas in second, what is recommended, that is 70% the blood sugar should be time in range, TIR, that I'll tell you in few more slides later on. And in the third, 100% of the blood sugars are well within the target what we want, 70 to 180. Still, all these three patients have the same HbA1c. So what is the basic difference? If you see here, you can compare this as if you take a picture through camera, that is what is glucometer. You're seeing 1 point sugar, that at that particular time, what is the blood sugar of your patient. Whereas this camcorder is a complete movie. That is what is CGM. You are taking multiple pictures. That is what the camera, the videography does, right? Similarly is our CGM, which records blood sugar every 1 minute or every 5 minutes or every 15 minutes, and it gives you a complete picture. So that's the basic difference between the CGM and versus glucometer. And this is just the evolution. You can see here that in 1908, there was urine testing for the glucose. Then came in 65, the first glucose strip, and then dextrometer, or the what you say glucometer is the same thing, that came in 1970 for the patient use, and CGM came in somewhere around 2000. So there are basically two types of CGM. The main two types are, first one is the real-time CGM. What exactly do you mean by real time? Real time is something you are seeing at that time. The blood sugar you can directly see on your meter. That is real time CGM. Okay. So data is conveyed directly from the sensor to your mobile phone or to whatever device the reader is there continuously. It's mainly mobile phone. Okay. So that is real time. It provides continuous glucose reading in real time, and it will alert the patient when the sugars are going very high and very low. Whereas in the flash this flash CGM or intermittently scan CGM, as the name suggests, flash. That means you have to flash your reader against the sensor. Sensor is something, a coin-like thing, which is installed in the arm mostly, and then you have to bring, it's like a pager like thing or a mobile like thing, that's the reader, and that you have to flash. That means it conveys through the NFC, near field communication, where you have to bring your reader near to your sensor, and then that sensor data would be displayed on your reader. That is what happens. That is flash or intermittently scan, that whenever you want to check the blood sugar, you scan your sensor through your reader. That is what you do in flash CGM. So what is the problem here? That the patient does not have continuous reading, though the sensor is checking blood sugar continuously. That is there. The sugars are being recorded in the sensor. That is okay. But the patient is not getting that information. Okay. So that is flash CGM. Whereas in real time, the patient is getting the data, the information real time. Okay. So it will give the data wirelessly to the smartphone, and that even can be conveyed to doctor and their caretaker relative, or like for small kids, type 1 diabetes kids, that data can be directly conveyed to the phones of their parents as well through the cloud. So that is the advantage of real time, so that if the blood sugar goes low, the parents of the patient, that kid, also know that the blood sugar are dropping. Okay, whereas this is not available in the flash. So this records the blood sugar continuously, but they do not transmit the data in real time. That is the basic difference. It's not that it does not record the data, it records the data every 1 minute. That is happening. That is the basic concept of your CGM. Okay, so this is flash CGM, which most of us are using in India. Then there is something called as professional CGM, the third type, where the data is recorded, but the patient cannot see, and retrospectively the data is given by the doctor to the patient. That is professional CGM. So third type is professional CGM. This is mainly for the doctors. Here you install the sensor on the patient, and after, let's say, 1 week or whenever you want to call the patient, you get the data from that sensor via your reader, and that you can download. That is a retrospective data what you are giving to your patient, because that event has already been over. Now the patient cannot adjust his food, diet, all those, that everything is over. But in real time, what is happening, the patient can actually modify his insulin or can modify his food. Like if the blood sugars are very high, he can restrict any carb food, or he can see that what is happening with what he's eating. All those can be seen in real time. Whereas in this professional CGM, that data or that information is not passed on at that time, though retrospectively we tell that patient, okay, you just write down whatever you are eating, whenever you are eating, what you are exercising, you have to make your food log, and then you come to us, and then on that we discuss with our patient that what is happening with his blood sugars. Now, what are the components of CGM? So there is sensor, as I have already told you, which is installed on the body of your patient. Then there is a transmitter, which conveys this data of the sensor to the reader, that receiver or the reader. Okay. And then there is a monitor, which displays your blood sugar, that or the data from the sensor. And then there is software which generate the overall report, AGP, ambulatory glucose profile. I'm coming to that. And then there is a printout of the AGP, that the total data of the 14 days, what were sugars, all those timing range, everything. Okay. Then few more important concept you should be knowing. There is warm up time with every CGM, that is different for different CGM. That is the time when it is taken by the sensor to get activated. It takes some time for the calibration to start. That is the warm up time. It is important because especially in all those closed loop insulin pump, that time the patient will, that pump will not have information from the sensor. So warm up time is important, especially in those type of cases. Then lag time, this is also really important. Lag time, as I've already told you, what you are monitoring is not blood sugar. What you're monitoring is an interstitial glucose reading. So there is some time taken for this equilibrium to happen. Let's say the patient blood sugar are changing too rapidly, then this will increase, lag time will increase. And let's say the patient sugars are very stable, so almost you can say that whatever the blood sugar, that is reflected in the interstitial fluid as well. So this lag time would be decreased. So this lag time can be anywhere from 5 minutes up to 20 minutes. So this is really important when the patient have hypoglycemia. So when the patient have hypoglycemia, you must ask your patient to check through the capillary blood glucose through a normal glucometer, because when he will eat something and again you want him to check after 15 minutes, so there is a lag time with the sensor, every sensor. So that will not be reflected in the CGM, but it would be reflected in your glucometer. So that is where you need a glucometer also. Okay. Then there's something called calibration of the sensor. Not all sensor need calibration, but some sensor need calibration where you need to check your blood sugar and you have to enter that data into the app, and accordingly the sensor would be calibrated and will give you better results, will the MARD will decrease. Okay, so that is important. So here calibration is also required for few of the sensors. Now this is how exactly this CGM work. So here you have a CGM sensor, then there is a transmitter. This senses the glucose from the interstitial fluid, and you can see that from the blood the glucose comes in equilibrium with the interstitial fluid, and that is what is checked with your sensor of the CGM. Now these are few CGM available in India: the Abbott one, Medtronic one, and the Dexcom one. The cheaper one is the Libre Pro, which costs you around something 2000 to 2500, which works for the 14 days. So that is a pro version. Pro is for professional, which we have already discussed. So it will not give you a real time data. You will have a retrospective data here. Okay, so that's a professional version. For Dexcom, you have G6 Pro. For Medtronics, you have iPro 2. So mostly we use this one. Blinded, that means that the patient will not know, but through some app, the patient can even know, but that is not what the company recommends. But now we have this where the patient can see the data, or even we have third party apps which via which the patient can, through their NFC enabled phone, can get the data directly from the sensor. And then we have some third party device also, again, which is not recommended by the company. So we have this Bluecon, where this pro version can be converted into real time. I've already told you, see, pro version, you cannot check the data, the patient cannot check the data directly, but what is happening, the sensor is recording it completely. It's continuously recording the blood sugars, so that data can be transmitted. So that is what this third party device are using. Okay, so this works for 14 days, this works for 10 days, this works for 6 days. Calibration is not needed in the pro version, it is needed in the Medtronic's version. And then I'll tell you all those steps, you can just uh, leave for now. MARD is the difference in the difference value. So lower would be a better CGM. Then coming to personal CGM, where the patient will have the access to his blood sugars. So we have two versions for Abbott. In fact, Libre 3 is also available. Libre 2 and Libre 3 are not available in India. Libre Pro and just the Libre, that is, I would say Libre 1, that is available in India. Dexcom G6 is available. Medtronic G Connect is available. Eversense is still not available in India. So these are the personal CGM. Again, there are some variation. So here you can see the Eversense will work for 3 months, and the warm-up time would be 1 day. Whereas for the Abbott, it works for the 14 days. Warm-up time would be 1 hour. That means after 1 hour, you can check the blood sugar through the CGM. Then Libre 2 is not available in India. It's an more advanced version where it can give data to the mobile app also, to the doctor also, but which is not available in the Libre version. I'm coming to more detail. Then we have Dexcom G6. It is available. Guardian 4 is the latest version we have available in India, which do not require calibration. Otherwise, the older version, Guardian 3, which was available till past, I would say 3-4 months, only 4 is available for past 3-4 months, that required 2 calibration per day. But the latest version do not require calibration, whereas calibration is not required for Abbott and Dexcom. You can just rely on that information you get directly from the CGM. Then above 18 years it was approved, but this newer one is approved for 4 years and above, and Dexcom about 2 years, Medtronics about 3 years. Then CT MRI, you have to actually remove all those, but you can take all your sensor through the airport, that is allowed. Yeah, so this Libre 2 is recently approved for insulin pumps. Initially it was not approved, it was approved 1 month back only. Then data sharing is actually available now with almost everywhere. Alarm is not available with the Libre. It's an scanned or the flash type of CGM, where you will not have a real time data, whereas this Dexcom is a real time. So it will give you alarms also. So these are the basic differences, and these are available in India, but mostly we are using the Abbott one. That is what I will be discussing in great detail, and then I will be discussing for the Medtronic one. Dexcom is available, but is more costly. That is why we don't use much in our patients. Okay, so coming to the first one, that is the Abbott Libre. Here we have two CGM. One is the Pro professional one, other one is the Libre. You can see here the reader is white. Here one reader is sufficient for all the sensor you want to activate. It's cheaper, around 2000 sensor, and then it's a professional CGM. Only one reader is required. The black one is the Libre one. It's a flash CGM. It is expensive. The reader would cost you around 5500. The sensor would cost you around 5000. One reader is required for each sensor. That's the basic difference here, because that the patient is going to take, right? Here the patient will flash this reader against the sensor and will check his blood sugar. So you have to give that reader to the patient, and that cannot be used for two sensors. Like let's say husband and wife both are using sensor, so they cannot use a same reader and they both can check on the same machine. It's not possible. Okay, so this comes like this in two kits. In one you have a reader along with a charger, along with a USB cable. The other one is the sensor. You have here applicator and the sensor. So sensor pack, you just need to peel it off the top thing, and then you have to remove this by rotating the sensor applicator, and then you have to push this sensor applicator on the sensor pack. Here you can see there is a line which should coordinate here along with this part which is protruded, and you have to push it. Once you push this sensor applicator on the sensor pack, this sensor is loaded on the sensor applicator. This is how it is done, and then you have to bring that this whole thing against your arm. Obviously you have to first clean, and then after that, once you put this, you have to press it and the sensor is applied, and there is a sound which tells you that now the sensor is applied on the body. And then softly you have to remove this applicator, and sensor would be placed wherever you have pushed it. Okay, that is how we put this Libre sensor. So this is around 4 centimeter, 3.5 centimeter. Now the newer version are even smaller. This is what is available in India. So 3.5 centimeter is the here you can see it is 3.5 centimeter into 5 mm thickness. This is your sensor. This works for 14 days. The patient cannot remove it between this. If the patient removes or it falls, then it will not work. Even when the patient is bathing, he can use this. He does not need to remove this. Even it is water resistant. It can be used even with swimming up to 1 meter of depth, up to 30 minutes. It is okay. You can use it. It is water resistant. It do not require any calibration. No calibration is required. You can directly. This is both for the Libre Pro also we have same sensor size and all those things same, and even for the Libre also we have same for the professional, and this there are same, all those things are same. So 14 days thickness, all those dimension are same. No calibration is required. Both are water resistant and easy to use, can be applied by the patient and captures data. That is both of them captures automatically. So here I've already told you that this is Pro first one, the second one is the Libre, and this is Libre 2, the blue one, which is not available here in India. Now these there is only one button, if you can see here, and the basic difference, if you can see here, there is a hole here in which you can put your glucose strip. That is available with the Libre and the Libre 2, whereas there is no slot available in the Libre Pro version. So it cannot be used as a glucometer. This one can be used as a glucometer, as well as it can be used for a ketone meter also. You can put the ketone strip and you can check blood ketone. Urine ketone, no, it's not for urine ketone, it's for blood ketone. So there is different strip for the blood ketone that can be checked with both these readers. Now this is compact, lightweight, And see, important thing is that when you talk about the Pro, the data is continuously recorded for 14 days, and the patient can come back and can give you the complete data. But for the Libre version, the data is recorded only for 8 hours in the sensor, whereas the memory for this reader is approximately for 90 days. That is what the data it stores in the reader. So every 8 hours you have to scan this sensor via your reader, otherwise the whatever last their data, that would be deleted. You can understand like that. If let's say in 12 in the afternoon the patient has scanned at 12 p.m., now he have to scan at 8 p.m. again, or before that he can even scan every minute. That is okay, every minute the data would change. So at least for after 8 hours he need to scan. Let's say the patient did not scan for up to 8 p.m., he scanned at 10 p.m., so he has delayed by 2 hours. So between this 12 p.m. to 2 p.m., the data would not be captured and the graph would not be created. There would be a blank at that time. Okay, so it deletes the data which is the most past data. It will delete for 8 hours. That is what the data is stored in the sensor for the Libre I am talking about, not for the Pro version. Then you have this one is a complete touch screen, and here you have a single button. It stores the data, scans through the clothing. 5 is the thickness of the cloth that the company says that you can scan through 5 of your cloth with the reader. Okay. Now, once, so there is a touch screen, and I'll tell you all those features also here. So once the sensor is activated, that is approximately 60 minutes after you apply, when you need to check the blood sugar, you just need to press this single button which is available. There is only one button, you have to press it. It will tell you to check blood sugar, and you have to bring this reader near to your sensor, and it will give you a reading. That is, you can see here 112. That is that what is the actual sugar at that time. Okay, that is what the reader is displaying. Then it will also tell you about the trend. Okay, that is up down changing slowly. So if you can see here, there is an arrow which is slightly 45-degree upwards. So if the arrow is right side is straight, that means the sugars are changing less than 1 mg per dl per minute, whereas this means it is changing more than 1 to 2. If this is right up 90-degree up, that means the sugars are changing by more than 2 mg per deciliter per minute. That means in next 30 minutes the blood sugar of the patient is going to increase by 60. Similarly, the downward will tell you, if it is right 90-degree down, that means the blood sugar is going to drop by 60 in next 30 minutes. That is what it shows. So it shows the trend so that the patient can act beforehand. That is what is an important of the CGM. Then you can see the history here. You will see that whenever the patient is scanned, the past 8-hour data is also shown on the screen. And then you have this pencil sign where the patient can insert what carb he is eating, what insulin he is taking, short acting, long acting. Then you have a timer here. Then you have battery. So almost it will work for 1 week. Then you need to charge it. And the cable and the adapter is available, that is given with the reader itself. And then you have this one line here, ends in 13 days. That means your sensor, it will work for next 13 days. That is what it is showing, the remaining time for the sensor. Okay, so with every scan the patient will have their present glucose, the past 8-hour history, the trend in arrow, and every 1 minute the trend is updated if the patient is scans, and every 5 minutes the data is stored for the Pro version, and every 15 minutes for the Libre version if the patient does not scan then also. Okay, so this is what is happening with your these two versions. So this I've already told you, current glucose, then glucose trend, history for 8 hours. Then you can put the footnote that what the patient is eating, how much carb he's eating, not what. You cannot put like apple, all those. It's showing an apple that is for this carb. You cannot put like two chapati something. It's not like that. Then on, if you press the button twice, the same here, the same button, if you are pressing it twice, it will give you two options: check glucose, review history. Okay. And it will also tell you about the time, battery life. This is also important because sometimes what happens, the patient changes the time zone. Let's say the patient is traveling from here to US. So time zone changes. So this is important. And accordingly, you will adjust your insulin. So time is also important, and that the patient need to change if the time zones are changed. Then you have setting where you will put all your what you want a TIR. Let's say for pregnancy, you want a lower TIR, higher TIR with a lower targets of TIR, right? So all those things can be done here. Then review history. If you click here, review history, it will give you multiple options. I'm coming to one by one. So, so the range of this CGM for the Libre is 40 to 500. Below this, it will not detect. Like your glucometer detects the blood sugar up to 600, and 20 to 600 in most of the glucometer will have range. Similarly, for your this CGM Libre, your range is between 40 to 500. It's slightly higher for the Medtronic one. Then below 70, it will give you an alarm that the blood sugars are low. Above 240, it will give you an alarm that the blood sugars are high. Then every time the blood sugar is scanned, every time the reader is used, it will make a logbook. And along with that, date and time would be displayed. And along with that, the trend and the blood sugar would be there. And also, if you have entered any food insulin, that will also be entered. And this can be seen on the reader also. And it will reflect on your AGP report as well. So this is what is logbook. Then you have a daily graph option. First one is the logbook option. When you will click the review history, these are the option you will get. So you will get the option of logbook. You will get the option of daily graph. Here, daily graph, that means every day the complete trend will be there. And what you see here, light gray or light blue color, is the target what you have made the setting. So here mostly we put 70 to 180. That is what is the TIR targets. So these are the daily graphs. Then you have daily patterns over 7 days, 14 days, 30 days, 90 days. It will give you a trend, it will give you daily pattern. Pattern will also have, this is like if you see for 7 days, this is the median, and 10 to 19 percentile of the reading would be shown here. So it's not for one day, it is an averaged for 7 days. So that is what is difference between the daily pattern and the daily graph. Daily graph, here you will get a single day blood sugar complete graph. Here it is daily pattern is actually averaged over 714, whatever you have selected, that it will give you variation for that. So 80% of the readings will fall in this 10 to 90 percentile. That means 80% of the readings are within this range. Then it will also give you average sugar for every 6 hours. Again, for that 7, 14, 30, 90 days, it is dividing into 4 quartiles of 6 hours, and it is giving you average blood sugar at that during that 6 hours, during that past 1 week or 2 week, 4 weeks, all those things. Then TIR, that is time in range, it will give you again for all those 7, 14, 30, 90 days that what was your TIR. So let's say if the patient is using a single sensor, then you cannot use for more than 14 days. And if the patient is not using sensor, let's say a patient has used sensors for 14 days and then not for 3 days, then again for 14 days, then it will also include those 3 days for the time in range, more this readings. Then it will give you hypoglycemic events. Again, you can change the settings here. You can make a slightly higher range for hypoglycemia, and it will give you that. It will again divide into 6 hours for 4 quartiles, and it will tell you how many times the patient have developed hypoglycemia. Coming to the Medtronic, this is about the Libre, about Libre. Now coming to Medtronics, here you don't have reader. Here what you have is a transmitter. sensor, and it's a real-time CGM. Data is directly transmitted from the sensor to your mobile. So that is what you're seeing. And what we are discussing is the Guardian 4, which do not require calibration. So here you have a sensor, you have a transmitter, you have a cloud software where you can convey the data to doctor, to caretaker, to the patient. So for the patient, this will also give you alerts from the prediction. It's a real-time CGM. Okay. It will directly show the data on the mobile. It will automatically upload the data on the cloud, which which can be seen by the doctor as well as by the patient caretaker. So this is the transmitter. This is the charger for the transmitter. This is how you place the transmitter over the charger, where it requires battery for charging. And then this is the applicator like we have there for the Abbott. This is for the Medtronics. Okay. So this is how you do it. So this is the sensor and this is the applicator. You need to peel off. Then you have to place it on the table. And two flanks, you have here, you can see one flank is here, the other on the other side. You have to place your hand and you have to pull it. And here, once you put it here, you have to put that applicator on this sensor and you will hear a click. That means this sensor is loaded on your applicator and now you can pull it straight. So this can be discarded, and here you will have this sensor inside your applicator. You have to place wherever you want to. Usually it's the abdominal side we prefer. You have to clean that area. Then you have to put that applicator on which the sensor is already loaded. You have to place it firmly on your abdomen skin, and then you have to press the two green buttons, which will give you a sound, and that means this sensor is now applied. Most important part is that you have to remove this applicator directly straight at the 90-degree. Otherwise, what will happen? This sensor can also come out. That's a big problem, practical problem. Once you have put this sensor, you have removed the applicator, then you will remove this needle. So this will look like this. Then this is another fixing tab which you will use to keep the sensor in place. The one is written, you have to remove this sticker, then two you will remove later on. Once you remove the part one of this sticker, you can place it like that. Then you remove the part two, so it will be attached here. After that, you place your transmitter. You have to just push it. Then again, you will hear a click sound and you will see here a green dot. That means the transmitter is getting information from the sensor and it is ready. Okay. And then you have to peel again this sticker and you have to put over the transmitter so that it does not fall. And then you can use another sticker to keep it in place. Otherwise, you can leave this step. Okay. And then you need to activate via your mobile app. It will again check your blood sugar like other sensors. It will give you real-time data. It can be used over 7 years. It will give you the trends, arrows, which I've already told you. Similarly, 1 arrow, 2 arrow, 3 arrow, like we have seen in the Abbott, by the degree of increase or decrease over 0 degree, 45 degree, 90 degree, -45, -90 degree. Same way you have here 1 arrow up or 2 arrow, 3 arrow, same thing, 1 to 3 milligram per deciliter per minute, increase or decrease. All those things are same. It's same. Now coming to the indication of CGM. So I would say almost all patients will benefit from CGM. It is especially recommended for those patients who have too much fluctuation, brittle diabetes, type 1 diabetes, recurrent decay, hypoglycemic unawareness, GDM, type 1 diabetes with pregnancy. All those patients would be really benefited. Not only that, those patients, let's say, who are just on few medication, they will also be benefited, because this will bring behavior modification, because they will be able to know that what you eat, how much the blood sugars are fluctuating due to that meal. Okay, let's say the patient is eating poha or patient is eating bread, whatever, he will be able to understand that how much his blood sugar increases or decreases due to that food. So it is actually helpful in behavior modification. Coming to the guideline from the RSSDI, so again the same thing: hypoglycemia, unawareness, pregnancy, children, infant, type 1 diabetes, hypoglycemia, all those things. Here again, insulin secretococcus, who needs again and again checking of the blood sugar, all those are, you can use CGM in all those patients. Then occupational risks like drivers and all those, and vigorously exercising, all those patients, you can use the CGM. That is what the recommendation. What are the barrier of using CGM? So there is barrier from the doctor side, barrier from the patient side. Patient side, obviously it's the cost, the most important thing. For everything you have to pay. Probably most of the insurance will not cover CGM under them. So cost would be a problem. Then fear of the patient for this, that this would be really painful, but it's not that painful. It's almost painless, I would say. So sometimes it is really difficult to convince the patient that it is painless, and they even don't try. Then sometimes the patient do not like that something is attached to his body. That is a problem. Then sometimes the patient does not want, especially those, I have a patient of type 1 diabetes who is something 15 years, and when I put a CGM on that patient, his friend says stop playing with him. So that is a problem, that something, it is still a social taboo in here, that the patient is having type 1 diabetes, so they don't want to disclose that they have diabetes. So this is a problem. Again, if you put a CGM, it is visible. Then too much information is also a really problem. It's an information overload. Now each and every sugar the patient sees, and then that causes distress, that now my blood sugars are increasing, my blood sugars are dropping. And mind you, you have to explain to your patient that TIR, that is target time in range, what you want is 70%. It's not 100%. It's not that 100% of the sugars you want between 70 to 180. 70% of the times, if your sugars are well within normal range, 70 to 180, that is very, very okay. We are back live. If you have some question, you can put in Q&A. I'll answer after the class. So there can be barrier from the doctor side as well. So doctor side, the problem is regarding the device that the doctor does not know, or maybe he feels that it is costly, or maybe he is not so experienced, maybe he's having less of time, maybe he's not techno savvy. All those things can be problem from the doctor side. The other, from the patient side, we have already discussed. Now coming to concept of TIR, that is time in range. So these targets are different, and time required for this, where the patient to be in this target, is also different. I'm coming to that. So TIR is nothing but the time is spent, whatever, like 70 to 180, most of the time you will put this target. So what is the time the blood sugars are between 70 to 180 in a day? That is time in range, as simple as that. So what are the metrics? Here you have mean glucose. GMI, glucose management indicator, is nothing but an estimated HbA1c, which was earlier called EHbA1c or estimated HbA1c, but it caused confusion. It's a numerical value in percentage derived from the mean blood glucose and some formula. So that is GMI, glucose management indicator. CV is the coefficient of variation, glycemic variability, how highs and lows are the sugar, that is coefficient of variation. It mainly deals with the low rather than the high sugar. Then you have TIR, I've already told you. Then you have TAR, that is time above range. Then you have TBR, that is time below range. Time above range are again divided into two levels. Level 1 is more than 180, level 2 is more than 250. TBR, time below range, is again divided into level 1, level 2. Level 1 is less than 70, level 2 is less than 55. Okay. So 54, 55 is level 2. Level 1 is less than 70. target is whatever you have made, 70 to 180 most of the time. Level 1 TAR is more than 180. Level 2 is more than 250. Okay, these are the metrics of CGM or AGP report. Now, what are the targets? So mostly for all your type 1, type 2, you will make the time in range more than 70%, and the target is 70 to 180. Whereas the above should be less than 25%, below should be TBR should be less than 4%. Whereas for the type 1 pregnant, this was for type 1, type 2, adult, non-pregnant. For the pregnancy, type 1, we have data. For type 2, we don't have much data. For type 2, as high as you can go for TIR, that is what the recommendation is. For type 1 pregnancy, you have recommendation same more than 70%. TAR should be less than 25%. What important thing to note here is that the target is different here. Earlier it was 70 to 180, but here it is 63 to 140. Something you do for your through your glucometer. If you see the target in pregnancy are 60 to 95 in fasting, less than 140 in 1 hour, less than 120 in 2 hours. So your TIR targets here are different. You don't want your blood sugars in a pregnant female to go to 180, right? So that is pregnancy. Then elderly, frail patient, again the TIR is here just 50%. You don't want it 70%. If you go 70%, that is well and good. The higher you go, that is better, without increasing hypoglycemia. That is really important, because in all these old frail patient, hypoglycemia is something you don't want. So that is why their TIR is reduced to reduce the TBR. Okay, the more tighter, the more stricter blood sugar you will control, the higher chances would be the patient will have hypoglycemia, and that is what you don't want. So if you see here, TBR is much more important here. TBR should not be more than 1%. That is what is your main target here. And again, the range is same, 70 to 180. It is something like what you do for old frail patient with complication. You make your HbA1c target slightly relaxed. You don't want their HbA1c to go to 6, 6.5, right? Their HbA1c you want somewhere 7, 8. That is okay. So same way as your TR, TBR, you don't want your TBR, that is time below range, to increase for old patient. That is important in this class. Now, what is the clinical importance of TIR? So it provides immediate information about the recent current blood sugar, and accordingly you can adjust your therapies. It, like HbA1c, gives you data over 3 months, and then you can have some actionable that you may increase or decrease. But here you can, at that point time, you can change the insulin dose, all those things. Then we have relation with TIR with HbA1c, and that is how your TIR targets were derived. I'm coming to that. Then it also correlates with the complication. We have data for that also. We have ample of data for HbA1c correlation with complication. We have data for TIR complication, diabetes complication relation also. So with each increase in 10% TIR, your HbA1c decreases approximately by 0.8. Okay. And why you are keeping your TIR to 70%? The answer is here, that you target your HbA1c something around 6.27, right? That is what the target in the guidelines is. And that correlates with TIR of 70%. Okay, that is how these guidelines and how these recommendations were made. So 70% TIR came from this, that it correlates with the HbA1c of 6.7%. Now, this is the report you will get, that is ambulatory glucose profile from the, if you connect your reader to the computer, this is the data you will get. Here you will know that what machine was used, what CGM was used. So here it is Libre, it's not the Pro version. Then here you have an estimated HbA1c, which is now changed to GMI. Okay, so it is an estimated HbA1c over 21 days, and this is the time period from which the sensor was put. And here every 2 hourly you will have an average sugar for that duration. So here we have taken data for 21 days. So every 2 hour data you have average over these 21 days. Then you have here median sugar. The darker line is 25 to 75 percentile, that is interquartile blood sugars it is showing, and this lighter one is showing from 10 to 19 percentile. Again, 80% of the blood sugar will fall within this range. So if you see here, it is very, very wide here around at 4 p.m. Okay, that means the sugars are going very low also, very high also. So as this graph widens, that is a tougher patient to manage, because his sugars are going down also at that time, his sugars are going very high also that time. So this is a tough time where this would be a tougher case to manage. Whereas here, if you see, the width of the graph is not that much. That means the sugars are following a particular trend at that time. Okay, so this is important to note. Then you will have this in the, this is, we are talking about the Libre version. Okay, in the Libre version, you will have an average glucose for per day. Then if the patient has entered carb, here you will get that how much carb he's taken in grams every day. Then rapid acting insulin would be written every day. Long acting insulin will be written every day if the patient has entered whatever he has entered. And then you will see a red mark. That means that the sugars were below whatever you have set. I have set here 70. So if you would set here 100, it will give you a red marking below 100. Okay, so I've set here 70. And then this, you will see a blue small dots here. That means that the blood sugars were checked by the reader. That means that reader was brought near to the sensor during this time, and the patient checked his or her blood sugar. That is what these dots are showing. Okay, and this increase is showing that the blood sugar are rising. Then here you can see a drop. All those things you can see. So what sugars are going at what time, all those will be recorded and will be seen here. And then this would be a more detailed graph here. Individual here, whatever dot is mentioned at that time, what were the sugars, that will also be shown here. Along with the insulin would be shown, carb would be shown, all those things will be shown, because this patient has not inserted any of those data and points. So that is not seen in our AGP report here. Now here, if you see on the first thing, here the graph is missing. That means the patient did not check. So like the patient slept at 10 p.m., he checked his sugar, the blood sugars were 119. And then he directly checked around 10, 9 p.m. here. That is why some data was missing. For 3-4 hours, the data is not recorded. That data is lost because the patient slept a longer duration and he did not check his blood sugar. That is why the data is lost here. Okay. Then red one is the blood sugar low, whatever target you have put there. And the yellow one are the sugars higher than whatever target range you have applied for the settings. So here you can see the red ones are the blood sugars which are lower than whatever target you have set. Yellow one are the higher sugars than the whatever settings you have made. Okay. Now coming to another AGP. This here you can see we have taken this for a pro version. Again, here estimated HbA1c is there, and the duration when the sensor was applied, when the data was extracted, it is seen. And here you will see that the sugars are not that highs and low. The graph is not that widened. So this means that this patient is much easier to manage. Also, you will see here that the target range I have put is 70 to 180. Here you can put anything, whatever you want, but it will not go below 70. It will not go beyond 180. So you can put like 80 to 140, 100 to 140, 70 to 140, but you cannot go beyond 180. So here in the pro version, what you will have is TIR, TBR, TAR, and the average glucose, because it's a professional CGM. Here the patient is not checking his blood sugar. He cannot insert his carb. He cannot insert his whatever rapid acting or long acting insulin he's taking, right? So here you will not get all those parameters. Here what you will get is average, TIR, TBR, TR. That is what you will get. And here the yellow one would be the above TAR, red one would be TBR. Okay, so these are the, and then date and ranges, all you can reset. Okay, and here the sensor will capture the data for 14 days. So here there would be no missing of data anywhere. So these are the data for that. Now, I've already told you that blood glucose is something which will be leading, and there would be some lag from the sensor glucose versus the blood glucose, and this lag would be lesser if the sugars are not fluctuating much. But if the sugars are fluctuating, the lag can be higher. So if the blood sugars are dropping, there would be drop in the sensor glucose as well, but it would be slightly later on. Okay, let's say like the patient is taking a meal, his blood sugar will increase. The blood sugar will increase earlier than the sensor glucose. Then he took insulin. So blood sugar will fall earlier than the sensor glucose, but sensor glucose will give you an arrow trend also. And then when there is activity, again, blood sugar will fall earlier than the sensor glucose. So that is how it goes. This machine also can have interference. It's not that it's absolutely errorless. It's not like that. Depending on what machine you are using, what method you are using, most of the time it is glucose oxidase monitors which these sensors are using. So if there is high ambient oxygen, if very high dose of aspirins are used, if higher dose of acetaminophen hydroxyurea are used, then there would be interference, and this can falsely decrease or increase your sensor readings. Now we'll be discussing few clinical cases. That is the last part of the session. You can just put your question in Q&A or chat box. I'll be happy to answer. Until we have this, we are going live again. I'll answer a few questions. Is CGM, Dr. Sujit is asking, is CGM affordable by most patients? I would say yes, because see, now you're getting this almost like 2,000, 5,000. And also, let's talk about a GDM patient. Already you want this patient to check his or her blood sugar somewhere around 7 times a day. So that means if you calculate, let's say the strip would cost somewhere around 15 to 20 rupees. That means she would be spending somewhere around 140 rupees per day. That means that within 15 days, she would be spending something around 2,000. And then you will have data for 7.7 times a day. Whereas this will give you around 300 times a day at least. Okay. So it is a good option then. Dr. Sujit is asking any data to show that there is impact of CGM on mortality and morbidity. So we have data for correlation, but exactly I don't have answer to that. Do we have data, because CGM are a newer thing and all those data are generated over longer duration. So we have data which shows that it prevents morbidity. It is cardiovascular events, all those nephropathy. We have microbinuria data. We have neuropathy data. We have cardiac event data. Yes. Then so Dr. Sujit is again asking, can we change instead of milligram per deciliter from millimole? Yes. Actually, these I've taken from the company slides. So it was made in millimole, but what sensor we are getting in India are in milligram per deciliter only. But let's say sometime the patient got the sensor from somewhere abroad, and then he brought only the sensor. You cannot activate it through your reader. So there is something coding country wise. So I had a patient whose relative brought them a sensor from US, so we could not get it activated. So sensor and the reader should be from the same place. Dr. Aryan Singh is asking, is other CGM available? We have already seen, yes, other CGM are available. Dexcom is available, Abbott is available, Medtronic is available, and now even the closed loop insulin pump 780G is available, and that can be used only with the Medtronic's Guardian. Dr. Aryan Singh is asking, how can we acquire FreeStyle Libre Pro? It is available in the market. Is it also available on the Amazon? Dr. Mangla Naik is asking, is there any skin problem? Yes, there can be itching and some skin irritation, allergic reaction. It can be there. But in practice, I have never seen that. It's mainly, I would say, theoretical. And then we have some topical steroid ointment also for that. Or you can use lubricant, or you can just change the site and that will go. Dr. Preetham Raj is asking, wearable watches. Yes, now it is a newer thing, I would say, via the infrared mechanism. It is checking blood sugar, but it is still under development phase. So it's not in market at present. Dr. Rachit Patel is asking, does CGM have any adverse effect on the skin? I've already discussed. Dr. Mishra is asking whether we can use in CLD. Yes, we can use in CLD, we can use in CKD, we can use in cardiac patients, we can use even in heart failure. The data shows that the reading does not change much. Okay, coming to the last part, that is case discussion. So these are my cases from my own clinical practice. So let's discuss the first case. This is a 59-year female. She is a known case of CKD. She came with a uncontrolled blood sugar with HbA1c of 9.2, with fasting of 166, postprandial of 300, and she already have a PTCA in 2013, stroke in 2020, and she's a CKD with a EGFR of 28, with DSPN, with diabetic retinopathy, and she was on dapagliflozin because she is CKD, CVA, and all those risk factors are there. So obviously she should be on this. And as her GFR is less than 30, we have not prescribed her metformin, and she is on insulin. Still, the blood sugars are varying too much with overall uncontrolled sugars because HbA1c is 9.2. The problem is that she has many hypos and many hypers. So that is why this patient was referred to me. So we got a CGM because this patient require a data. A pro will not be a very good option for her because she want to adjust the insulin right then and there. Okay, so we installed a Libre. We gave her a Libre sensor. So see here on 11th of Feb, I put the sensor. The blood sugar was 500, but this is average over just 6 hours, so you can just leave it. Then you see here the blood sugars are dropping right from 500 to less than 70. You can see here red. And then again, it is increasing to somewhere around 400, 500. You cannot see it in graph. Okay. So that is the fluctuation you see in this patient. And she was already on basal bolus plus dapagliflozin. So if you see here over 4 or 5 days, we adjusted the insulin daily, both the basal and the bolus, and you can see the sugars from right from 500 to the 60. So much of fluctuation. This is gradually decreasing now. At least it is coming in graph, and the main target is this patient should not have hypo. This patient is having too much comorbidity, right? And she also have neuropathy. So maybe she have unawareness also, right? So this, with adjustment of the food and the insulin, these are slightly getting better. And you can see here that we have put just on 11th of Feb, that was day one, and within a week, that is on 18th of Feb, the sugars are getting much control, the hypos are being reduced, and here you can see almost what you want. Time in range is even more than 70%, I would say, though it's not a correct method to tell the percentage here, right? And here you will see that the patient on Sunday again went out and the blood sugars increased. She went out to eat. So this is what the patient will also know, that what is happening with him. And we would also know, and we would be better, we will be better able to guide that patient what to do and what not to do. Now coming to another patient. This patient came to me that he's following his lifestyle. He's from a well-to-do family. He follows everything. He does exercise, everything, all those things. And he is compliant to medication. What was his issue is that whenever he gets his HbA1c checked, it is high. And whenever he checks his blood sugar, it is normal. Obviously the answer would be from any one of us would be that maybe his glucometer is false, or maybe this HbA1c report is false. So what we did is we got the HbA1c from HPLC method, and we also got few lab blood glucose. But again, the trend was same. The this is from lab. Fasting is 112, PP is 173, and the HbA1c from the HPLC is 9.8. Now you have to answer why. So what I suggested that, okay, we'll put a pro version because your sugars are, I feel it's okay. Let us see that what is happening, why there is discrepancy between these two, because there are n number of things which can cause your HbA1c to increase, as we have already seen. So let us put a CGM Pro, right? Because this person do not require a real-time data. He does not want to know. Even a retrospective lower and less costlier CGM would be fine. So he is already on metformin 2 gram, empagliflozin 25, gliclazide 120 mg. So we installed a pro version. You can see here pro is written. Okay. And you see here his HbA1c estimated was 7%, and these are his blood sugars with not too widened graph. And we installed this on 13th of December, and you see here his PPs are increasing, and his time in range is not what is recommended. He does not have any comorbidity. We want something more than 70%, right? So with this, after we have installed this for 4 or 5 days, I've called him on after 5 days. So he came on 17th December again, and I've told him that this is the problem, that your PP is slightly increasing, though after 2 hours it settles down. That is the problem. This is happening. So what we did is we modified the food slightly, and now you see just after a week, from 13 to 17, up once he came on 17, this is a retrospective data. So we told him to manage his food, and now you see from 18, 19, 20, what is happening. His time in range is increased to 98, 97, 96%. So that is the importance of behavior modification. That is the importance of your food modification, and that is the importance of CGM, where you can actually guide your patient that what is wrong with him. Coming to another case, now this patient was referred to me post hysterectomy. Like usually what happens, then everything surgery and everything is done, and then you will get a call that now you manage this patient for blood sugar when everything is being done. So this is a 73-year female with diabetes of 25 years, already on insulin, glargine U100 14 units, along with glipizide, metformin 850 BD, and lipaglyn 5 mg. Okay. So this patient was again having too much hypos and hyper, and she is a 73-year-old lady, well to do, and she does not want to prick again and again. So we advised her a CGM, not the pro version, the Libre version. Now you see here on 14th of April, we got the CGM, and as the sugars were increasing, we slightly increased the insulin by 2 units. That is what we did. And you will see here that every night she is having hypos, right? So again, we decreased the blood sugar, then again it got increased, and especially this pre-dinner, that was coming slightly higher than what is recommended, though the TIR was good enough, but still we can further improve it, because we don't want her TBR, because she's a 73-year-old. We don't want her TBR to be less than 1%. So her TBR was coming 2%. So that is not what is recommended. Though the TIR is 75%, that is good. But we don't want her TBR to be less, to be more than 1%. That is what is recommendation is. So we adjusted the insulin, and we change this insulin from a basal insulin to a premix with a second generation basal insulin. That is what we did. We changed the glargine to IDEC aspart in morning, because her post were also increasing. So that is what we did. So once we changed this insulin, this was again the same thing happening when we increased the insulin. You can just skip this. Now what happened? See, this what the drop at night were not there. Also, the increase that was pre-dinner, that was significantly decreased. Initially, the blood sugars were well within target range. That I do understand. It was 75% TIR, but this TBR was not acceptable to me. So we changed the insulin, and this is data actually over 14 days. So it will capture data for both. So this improved her TBR with increasing of TIR. That is what happened. Though this is a 14 days data, so it will capture both the data. So thank you for your patient hearing. Now we can have a question answer session. If you have any question, I'll be very happy to answer. Dr. Mangla is asking, is it painful? No, it's not painful, I would say, though I have not experienced myself, obviously. One of the anonymous doctor is asking, How to manage sugars which are fluctuating? See, this is a very broad question. I would say it depends on what the patient is eating, what medication you're doing. Let's say a patient on basal bolus, that's a totally different thing. If the patient is on just on metformin, that's a totally different thing. If the patient wants to eat rasgulla with insulin, nobody can help him, right? So it depends on patient to patient. It's a very vague question, I would say. Dr. Avinash is asking, generalized edema and high INR, do they affect? See, edema, I would say, until unless patient is hemodynamically stable, it does not affect. That is what the experts say. But obviously, we don't have study for that. Dr. Rachit Patel is asking, can you please explain why in some of your patient you are using Libre and in some Pro? See, if you want, obviously a Libre would be better than Pro, because whatever data you have with Pro, you have data with Libre. I agree on that. But the cost is almost 2.5 times. The Pro version you will get in somewhere around 2000, whereas the Libre version you will get in 5000. So if the patient does not require that, why do you want to spend 5000 from the patient? Anonymous attendee doctor is asking how to initiate Rhizodex. See, we have already covered in great detail about the insulin initiation. You can just go, it's an 2-hour class. Dr. Preetham Raj is asking what is preferable, either CGM alone or closed loop. So again, it's a different talk. We cannot discuss here, but obviously again, it depends on patient to patient, what your patient is and what how exactly he's performing. I think I've answered all the questions. If you have any further question, you can just mail to the tech team. I'll try to answer all those questions. I think it's already 1.5 hours and we can end the session now. So thank you everyone who has joined in live and have spent their valuable time to listen to me. And we had a great discussion. And I would further appreciate if you have any question, you can ask. Okay. Thank you, Dr. Preetham. He is saying thank you very much. It was great session. Any of your feedback or any question? We'll wait for 2 more minutes and then we'll end this session. Though I have discussed more like clinical cases also, until unless you use it, you will not be well versed with it. I know that. So it was just more of a sensitization type of thing, so that you know that how exactly this work and how to use it, where to use it, and which of your patient who would be benefited most with this. So with that intent, I've created this session. Okay. I think there are no further questions. We can end this session. Thank you. Thank you very much. Have a great day.
Thank you, sir. Thank you for the wonderful session. Thank you, participants, for joining.